Good evening, everyone, and good evening, all the faculty and delegates to join the webinar. It's a great pleasure to welcome you all Onco Update 2024 in GI and Hepatobiliary Cancer. And I would like to invite Dr. Ankit Batra sir to give his opening remarks. And he is an Associate Professor Medical Oncology, CRIHIMS, Dehradun. So it's over to you, sir.
Yeah, very good evening, everyone. And we are going to discuss the Onco updates in 2024 with a focus on gastrointestinal and hepatobiliary cancers over the next 2 days. It's a webinar being planned for a site specific, and I hope everyone contributes with their updates and knowledge into these webinars so that we become more wiser and provide a better care for our patients. And I think to begin with, uh, in oncology, the base is a good pathology and a molecular oncology, which is the need of the hour and is evolving very rapidly. So, to begin with, we have our first speaker, Dr. Sunil Pasricha, sir. Sir will be talking about the newer paradigms in the HER2 pathology, especially related to the gastric cancers. And with this, I would like to invite Dr. Sunil Pasricha, sir. He's a senior consultant and molecular oncologist at the precious Rajiv Gandhi Cancer Institute, New Delhi. Over to you, sir.
Thank you, Dr. Ankit, for the kind introduction. So can I share my slides?
Yes, sir.
They are, I think, it's a full screen showing.
Yes, sir.
That's moving. Okay, so I'll be talking about the role of the molecular testing in the GI oncology, including the HER2 positive gastric cancer. So the cancer of the gastrointestinal tract are a major cause of morbidity and mortality globally, and there have been intense efforts to personalize therapies for these patients by the way of predictive biomarkers. Now, the biomarker profiling of the GI cancer is phenomenally diverse. So unlike lung, where we get to see the need of hour is the multi-gene assay, that is by the NGS. The GI cancer require assessment of an impressive and growing array of the immunohistochemistry-based marker like MMR, HER2, and PD-L1 immunohistochemistry. Another important peculiarity in the GI cancer is that the biomarkers in GI cancer, they cannot be interpreted in isolation and they are interrelated. So the clinical significance of one biomarker, it hinges critically on the presence or the absence of the other alteration. For example, the detection of a BRAF mutation in colorectal carcinoma to a large extent is meaningless if the result of MMR immunohistochemistry or MSI testing is not available. Similarly, the interpretation of PDL1 result in a gastroesophageal cancer is very much dependent on the tumor HER2 status, which I will be covering in my subsequent slides. So I'll start with the colorectal carcinoma. So we are all familiarized that the great majority of the colorectal carcinomas, they are sporadic and just a fraction, small fraction is inherited. And very important to delineate the subset, which is the MSI high. 12% they are attributed to sporadic, and the 3% are attributed to the germline mutations due to the Lynch syndrome or the mutation associated polyposis. Whereas in the sporadic, the 12% which are attributed to sporadic, they are due to the hypermethylation of the MLH1. So what is the aim of the biomarker testing in the colorectal carcinoma? The most important is to detecting the Lynch syndrome and screening, predicting the response to NG-EGFR therapy, therapeutic decision making, especially in the stage 2 colorectal carcinoma for the de-escalation of the therapy, prognostic significance and therapeutic monitoring, and selecting the candidates for the immune checkpoint inhibitors. So MSI testing, we know that it has stood the test of time, and in 2019, way back, the NCCN recommendation was that MCI status should be evaluated in all the newly diagnosed colorectal carcinoma cases. So there are two ways. One is the MSI testing by the PCR, and the other is the which we are commonly using, and it is the first modality at our institute that we are testing it by the MMR testing by immunohistochemistry. We are testing all the 4 genes, which are the MMR genes. So if there is no loss of the nuclear expression of these proteins, we call it as a MMR proficient, and it signifies low probability of MSI high. And the other profile is the loss of nuclear expression of one or more than more proteins. So we call it as a, if there is loss, if we call it as MMR deficient, and that signifies the high probability of MSI high. So in this picture, you can see the left side is the normal colon and the right side is the tumor. So we can see that the nuclear expression is retained of the protein. So we label it as a MMR proficient. But in this case, you can see on the left side, the normal colon is having a nuclear staining, whereas on the right side, the tumor is showing the loss of immunoexpression. So this case will be labeled as MMR deficient. So what are the advantages of immunohistochemistry over the molecular testing for detecting the MSI high? The great advantage is that it's readily available, low cost, more labs can do it, training is quite easy. The key advantage of using immunohistochemistry is to evaluate the individual gene defect and may strongly suggest a possibility of a Lynch syndrome even on IHC straight away. Whereas the molecular testing PCR revealing a MSI high may result in either sporadic or the germline, the Lynch syndrome, the dilemma will persist. However, if the IHC testing which shows a loss of MSH2 or individual loss of PMS2 or MSH6, they are exclusively described for the patient with the Lynch syndrome. So if you have a loss in these markers, you can safely label the case as a Lynch syndrome and proceed with the germline testing. So what are the advantages of molecular based testing by PCR or by Sanger sequencing? So it is 93%. So PCR based testing, which is commonly employed, shows 93% sensitivity. The MSI testing may be positive and helps to detect Lynch syndrome when MMR testing by IHC is false proficient. Why it happens? Because there can be some missense mutation in up to 5 to 8% of the cases, especially in the MLH1, which can lead to formation of a non-functional a truncated protein which has a retained antigenicity. So that this can give rise to a false MMR proficiency on the immunohistochemistry. So this is the algorithm that we follow, and you can see here. So if we start from the left, if there is a MLH1 loss, so the next thing is that the dilemma will be there whether it's a sporadic or a germline. So we have to go with the BRAF mutation. If that mutation comes positive, you can label the case as sporadic MSI high. But if it is negative, the dilemma will persist. So whether it can be again sporadic versus Lynch syndrome. So what you have to do is you have to go for the methylation specific PCR. That is the CpG island methylation phenotype. If it is positive, we can label the case as sporadic, but if it is negative, we have to consider for the Lynch syndrome. So we have to go for the germline mutation analysis. But on the other hand, if you have on the right side, if you see, if you have a MSH2 loss or you have an isolated loss of PMS2, MSH6, it is very much and highly suggestive of a Lynch syndrome. So in this case, on IHC, you can straight away proceed with the germline mutation analysis. And in the Lynch syndrome, more than 90% of the cases, they show germline mutation in MLH1 and MSH2 genes. So coming to the prognostic and predictive value of the MSI high tumors. So it is a good prognostic biomarker, especially for the stage 2 colorectal carcinoma patients. The adjuvant chemotherapy can be avoided in the patient with the MSI high who are stage 2, but we call it as a de-escalation. Sometimes when we have the node is negative, but there is a breach in the serosal aspect of the colon. So they become clinically stage 2C. So it's a dilemma whether to give a chemotherapy or not. So if the MSI is high, so we can go for the de-escalation. No need to give chemo. The prognostic value is more pertinent in the stage 2 rather than stage 3. And immune checkpoint inhibitors, they led to substantial therapeutic benefits with a 4-year overall survival in more than 70% in metastatic colorectal carcinoma positive for the MSI high or deficient MMR status. Although this looks very encouraging and rosy scenario, but in practicality, this biomarker for immune checkpoint inhibitor applies only to 4% of all the metastatic colorectal carcinoma cases, leaving most of the patient to rely on the traditional chemotherapy and incremental gains from the new biological agents because the incidence of MSI high in the metastatic colorectal carcinoma is quite less. Coming to the next important biomarkers, the KRAS and the NRAS mutation analysis, they are required for the frontline anti-EGFR treatment decision making for the metastatic colorectal carcinoma. The frequency of KRAS is 40 to 50%, while of NRAS is 3 to 5%. The mutations in KRAS and NRAS are predictive of the lack of benefit for the anti-EGFR treatment. So the patient with the RAS wild type who are left-sided, they demonstrate excellent outcomes with the anti-EGFR based therapy. And although the great majority of the mutations, they are seen in exon 2, that is codon 12 and 3, but we have to do extended or the expanded RAS panel as per the NCCN guidelines because there are few mutations which are seen even in exon 3 and exon 4 on codon 59, 61, 117, and 146, which also has a equal significance as that of the conventional mutations. So this is how we detect the KRAS mutation on PCR. And the KRAS mutations, they are more prevalent in the left-sided tumors, and they are more associated with the microsatellite stable colorectal carcinomas. The most common KRAS mutation in the colorectal carcinoma is KRAS G12D, which is seen in 36%, while KRAS G12C mutations, they are found in only 3 to 4% of the cases. The KRAS mutations, they confer a bad prognosis across all the age group. And among the specific subtypes, the G12C demonstrate the worst prognosis relative to the wild-type tumors. And multiple studies, including the phase 3 Crystal and Prime trials, they have demonstrated that the KRAS and RAS mutations, they predict a poor response to combination of the chemotherapy with the EGFR inhibitor, that is panitumumab and cetuximab. The next biomarker is the BRAF gene mutation testing. It's a immediate downstream effector of the KRAS in the MAP kinase signaling pathway. The most common BRAF mutation is the BRAF V600E, where valine is substituted by the glutamic acid. The BRAF mutations, they occur in 8% of the advanced disease and in approximately 14% with the localized stage 2 and 3. So the clinical pathological characteristics that are associated, that includes the proximal tumor location, aggressive growth, unfavorable metastasizing patterns, the EGFR blockade resistance, and reduced overall survival. The pooled analysis from the three very important clinical trials noted an increased frequency of MSI high with the BRAF mutation as compared to BRAF wild type. However, the monotherapy with the vemurafenib or dabrafenib is ineffective in V600E metastatic CRC due to the alternative MAP kinase activation mechanism maintaining the elevated MEK activity. So that leads to constitutive activation of the transcription pathways and tumorigenesis. So compared to the chemotherapy control in the pre-treated BRAF V600E metastatic CRC, both doublet, that is encorafenib and cetuximab, and triplet therapy, encorafenib, binimetinib, and cetuximab, they demonstrate a superior overall survival and PFS in the phase 3 Beacon trial. Encorafenib plus cetuximab combination is an approved second-line regime in BRAF V600E metastatic colorectal carcinoma. So again, we did the method of choice is, if you are going for a single gene, is the PCR. So HER2 is an established therapeutic target in colorectal carcinoma. The NCCN guidelines recommend HER2 testing for all the metastatic colorectal carcinoma patients present in 2 to 6% of the cases as per the various studies that have been done. In the second line setting for the metastatic colorectal carcinoma, the RAS BRAF wild type patient with HER2 overexpression or amplification who have not received the prior HER2 inhibitors, they can be treated with trastuzumab in combination with pertuzumab, lapatinib, or ticatinib. The Heracles trial, the phase 2 study of a heavily pretreated patient with the KRAS wild type, the HER2 positive metastatic CRC, they demonstrate the efficacy of dual HER2 blockade using trastuzumab and lapatinib with an objective response rate of 30%. Then there are various studies like My Pathway Basket study, which have actually tried the HER2-directed therapies of trastuzumab and pertuzumab in a treatment-refractory colorectal carcinoma. They reported an overall response rate of 38%. While the combination of trastuzumab and tucatinib was the first HER2-directed treatment approved by FDA for the chemo-refractory metastatic CRC based on the Mountaineer trial. The ongoing phase 3 trial Mountaineer 3 is investigating the tucatinib and trastuzumab in combination with chemotherapy in the first-line setting compared to the standard care in HER2-positive patients. And recently, the Destiny colorectal carcinoma 01 phase 2 trial of the patient with HER2-positive metastatic CRC who had received at least 2 prior lines of therapy, PAM trastuzumab deruxtecan, was associated with an overall response rate of 45%. So wherever the pathologist is reporting, the criteria is different as we follow in the breast. So the medical oncologist should ensure that the reporting has been done as per the Heracles diagnostic criteria. And and even in the Destiny trials also, so there are basically 3 types of assays available, and the 4B5 is the most preferred assay, and we are using the same in our institute, which is from the Roche. And that has also been utilized in the Destiny study also. So the eligibility criteria is that if you have a circumferential membranous staining that is complete, intense, and more than 50%, the patient is straight away eligible for HER2-directed therapy. Coming to the NTRK, it's a frequency being around 1% in the colorectal carcinoma. However, greater than 5% frequency is seen in the subset of the deficient MMR or MSI high. And they are associated with high tumor mutation burden, MSI high, and enrichment in POL or POLD mutations compared to the molecularly unstratified colorectal carcinoma tumors. The first generation TRK inhibitor, which are approved in tissue agnostic fashion like larotrectinib and entrectinib, are approved. However, after 6 to 7 months, they show resistance. And now the second generation NTRK are in trials, which have shown some promise over the first generation. The recommended method for NTRK, because the incidence is so low, it is the NGS, and for a single gene, it is a FISH. There is a immunohistochemistry. We are using it for last 4 or 5 years. The IHC clone EPR 17341, which is recommended. But these standalone, but this is just a sensitive test. It is not specific. So if even if on IHC it comes positive, it has to be confirmed on molecular, just like we do for ROS1 in lung cancer. So coming to the gastroesophageal carcinoma. So regarding MSI, MMR testing, so I have already spoken about this. And so there is an uncertainty surrounding the rate of MMR defects in the gastroesophageal cancer. And for the gastric adenocarcinoma, the most series have placed it in the range of 10 to 20%, with the prevalence of being substantially lower in the esophageal cancer. And at our institute, the incidence is not more than 10%. It's somewhere around 8 to 10% in our experience. The main role of MMR MSI testing in the gastroesophageal cancer, again, here is to determine the eligibility for the immune checkpoint inhibitors. Coming to the HER2 overexpression or amplification, so HER2 directed therapy like trastuzumab has been approved in the advanced gastroesophageal adenocarcinoma in combination with chemotherapy, and based on the positive results of the TOGA trials. The scoring system here is different. Again, what we are using in the breast is not applicable here, and that's the Rashov-Hoffman system is used. And it differs from scoring system in breast by taking into account the marked heterogeneity of the HER2 expression, which is seen in the gastroesophageal tumors, and different criteria for assessment of biopsy and the surgical resection specimen. So in a nutshell, the patient who are eligible for trastuzumab or HER2-directed therapies is when the staining is 3+, or it is a 2+, but subsequently FISH amplified. So this is the Rashov-Hoffman system. So the major difference is that in the biopsy on the right column, if you see the biopsy specimen, unlike the breast where the 10% is the criteria, here you don't have the 10%. You have a tumor cell cluster in all 1+, 2+, and 3+ scoring. And what is a tumor cell cluster? That you have at least a contiguous cells of 5 cells, but they should be contiguous. You cannot cherry pick one cell over there and one cell over here. So a contiguous cluster of 5 cells is considered as a tumor cell cluster. So Destiny Gastric 01 Gastric 01 trial has shown the efficacy of trastuzumab deruxtecan in HER2 positive or amplified gastroesophageal adenocarcinoma. However, there is a spatial and temporal heterogeneity well described in the HER2 expression, a frequent phenomena which presents a challenge in identifying the patient who may actually respond to trastuzumab deruxtecan. So the awareness of location and histology can be helpful in evaluation of the HER2 result in gastroesophageal adenocarcinoma. So what are the clues? The HER2 overexpression is more commonly seen in gastroesophageal junction adenocarcinoma than in gastric. And also it is more commonly seen in intestinal type histology rather than diffuse, or what we see is the signet cell. So it's more common in intestinal type histology. And well to moderate differentiated adenocarcinomas are more likely to overexpress HER2 rather than poorly differentiated adenocarcinoma. So it is recommended for the pathologist to select the block for testing with the tumor which is showing a good differentiation to perform the HER2 IHC. So this is one of the cases I have pulled back from my case library, and you can see the upper is the HE showing both areas, the well to moderately and the poorly differentiated. And in the lower HE, I have taken the high power, and you can see it's a moderately differentiated, showing a gland formation. And you can see the HER2 is nicely positive in these gland forming areas, while absent in the poorly differentiated. So the exploratory results from the additional data of Destiny's Gastric 01 trial suggested that there is a potential benefit in the patient with the HER2 low gastric cancer. But the low HER2 has a problem that has been realized in various studies, and this is a recent publication by Angelilli et al. And this study comprises of a large multi-institutional data, and what they found that the percentage of HER2 low in the biopsy specimen was much higher, it was 35% as compared to resection specimen. The reason being, the biopsy, the criteria is the cluster, just 5 cells, whereas in the resection specimen, it goes with the 10% tumor area criteria. And also there is a wide range of HER2 low results among the various institutes. So there is a massive problem of the inter-observer variation. So the international guidelines now recommend that at least 6 samples should be obtained. That is, the 6 cores should be there from the neoplastic tissue to take care of the heterogeneity. Coming to the role of PDL1 in the gastric or the G junction carcinoma. So we know that PDL1 is an immune checkpoint inhibitor whose expression, at least in some cases, is associated with increased likelihood of response to immune checkpoint inhibitor. So we are all familiarized that number of immune checkpoint inhibitors requiring the PD-L1 assessment are now approved in the gastroesophageal cancer, depending upon the CPS, TPS, and they have a different cutoff. I will not recite all this. So the recent one was the first line pembrolizumab in the advanced gastric or gastroesophageal adenocarcinoma with the PDL1 CPS more than one. And this is combined with chemotherapy for HER2 negative tumors. And with both the pembrolizumab along with the chemotherapy and trastuzumab for HER2 positive tumors based on the Keynote 811 trial. So there is no universal definition of the positivity of the PDL1. The definition of positivity depends upon the tumor type and the drug which, which the medical oncologist is intended to give to the patient. So this is how we calculate the TPS or the CPS. So in the TPS, we just take care of the positive stained tumor cells, whereas in CPS, not only the tumor cells, but also we take care of the, we include the mononuclear cells, that is the lymphocyte and macrophages, but not neutrophils, just the mononuclear cell. And the denominator is the total number of viable cells multiplied by 100. And this was my elaborative publication. I did it with my former colleague, medical oncologist Dr. Venkats. So here, but we have published an elaborative article on to address the practical considerations for both pathologists and oncologists for the PDL1 testing. But if there is any pathologist in the forum, can go through this. Lastly, the recently emerged or the emerging biomarkers. So Claudin 18.2 IHC has now emerged very recently and as a predictive biomarker in the gastric cancer, especially adenocarcinoma of the gastric or the gastroesophageal junction adenocarcinoma, and the drug zolbetuximab, which is the antibody drug conjugate, along with the modified FOLFOX in the patient with the who are having this biomarker positive, and but they should be HER2 negative, untreated, locally advanced, unresectable, or metastatic gastric or gastroesophageal junction adenocarcinoma. And the results were encouraging based on the Spotlight trial. And the positive criteria is that more than 75% of the invasive tumor cells should show a membranous staining of not only just 3 plus, even a 2 plus intensity will also qualify. And with this criteria, 30 to 50% of these cancers, they are positive for the Claudin 18.2. Lastly, the FGFR2b expression. So the drug bemarituzumab has been shown to have efficacy in the HER2 negative gastric or the gastroesophageal junction adenocarcinoma, which are positive for the overexpression by the immunohistochemistry. And this was the results were encouraging in the FIGHT trial and in the FGFR2b positive advanced gastric cancer. The combination of bemarituzumab along with the modified FOLFOX led to numerically longer median PFS and OS as compared to the chemotherapy alone. The efficacy was more pronounced in the FGFR overexpression in more than 10% of the cells. However, the confirmatory phase 3 trials are still ongoing. So I would like to wrap up. The cancers of GI tract are now associated with a wide array of clinically relevant biomarkers. The biomarker profiling in these malignancies are complex and challenging. As the era of targeted therapies continues to evolve, the development of companion diagnostics and predictive biomarker becomes increasingly crucial. So it's incumbent upon the pathologist to make the testing reliable by optimizing pre-analytical, analytical, and post-analytical steps. Thank you very much. Would be happy to take any questions if you have.
Thank you so much, sir, for such an elaborative talk. I think I was just thinking about the question which you have already uh, cleared in your last line. So, the HER2 testing and the usage with the addition of newer drugs, especially the TDXT, is very exciting, especially in GI oncology, be it G junction, gastric, or BTCs or colon. So, my main query was like, is it the testing is same what we are doing in breast? Is it that easy or it is more complex in the GI? And how do you look forward, especially for the uh, trainees in pathologies or those who are working in tier 2 and tier 3 cities? How do we take that testing, especially when we are using costly molecules like TDXT?
So basically, see the experience is the best teacher, and the thing is that we always have to update ourselves. Like even for the although I'm reporting HER2 for the last 15 years in this institute, but even when the concept of low HER2 came, so even I myself underwent a proficiency testing, the training and evaluation. So I think all pathologists who are actually doing this biomarker testing, which are very critical, having an associated therapeutic implication, should enroll themselves in the proficiency testing and training and should get them updated and for that. because see, the guidelines we have to follow. It is not something very difficult to interpret, but only the thing is that the conventionally we are all reporting the HER2 in the breast where the criteria are different. So here the criteria is different as compared to breast. Like I have just shown that in gastric biopsy, you don't have to take the 10% cutoff into the criteria. You have to take off the contiguous 5 cell cluster. And similarly for colorectal, you have to take into account the Hercules criteria. So if so, in the colorectal cancer, suppose if you have a 20% tumor cells showing a strong positivity, had it been a breast, it would straight away be eligible for the HER2 directed therapy. But if you have a 20% strong intensity in the colorectal carcinoma, so here the FISH test becomes mandatory. So I think if you follow the algorithm or the flowchart of the guidelines, plus if we update, I think it's not something difficult. It's quite easy.
Yes, totally agree, sir. Thank you so much, sir. So we'll move on to our next talk, which is on the role of Obdita Gangaram Hospital, Delhi. So welcome, Dr. Aditya. Over to you.
Good evening. So, Dr. Ankit, I was hearing to your previous comment. You do have the approval of giving chemo with nivolumab. It's a category 2B recommendation. I mean, no, somebody will not be 100% wrong in giving it. Yeah, obviously, the prognostically giving IO in a patient with less than 10, I think it's a bad prognosis. But yeah, I mean, there is no, as such, no, that you're not supposed to do this. It's not that way. That is
So,
how I see. I mean,
so that's what previously the house was divided whether to give in negative or less than five patients or not.
House,
And
house is
recently
always
I was,
divided. It's you that you
yeah,
have to decide. House, house.
recently I was attending a meeting 2 days back. So there I got to know about an update from FDA that
Yeah.
they discourage in using CPS or maybe PDL negative patients.
So yeah, as soon as it's out of the guideline, it's out of the guidelines. मतलब we have to follow something, भाई. मतलब इतना कुछ हो रहा है. हाउस तो हमेशा डिवाइडेड ही रहना है. हाउस का कंक्लूजन बड़ा मुश्किल ही होता है कंसेंसस आना. Anyways, okay. So yeah, changing paradigm in the management of esophageal cancer. So I'll be having a very short and crisp talk. It's IO, which is pembrolizumab in advanced esophageal cancer. It's a first-line treatment option for patients with locally advanced unresectable or metastatic carcinoma of the esophagus. Obviously, the patient should have an HER2 negative G-junction adenocarcinoma and a CPS of more than 10 or equal to 10. So, esophageal cancer was the eighth most common cancer and sixth most common cancer-related deaths worldwide. And globally, an estimated of 6 lakh new cases of esophageal cancers were reported in 2020. If we were to come to Asia, you have approximately 5 lakh patients with a mortality of 4.3 lakhs and a 5-year prevalence rate of approximately again 5 lakh patients. So, what about the histological subtypes? Obviously, we all know there are two types. It can be either a squamous cell carcinoma, most common esophageal cancer worldwide, and the highest incidence rate in the Eastern Asia, Eastern Africa. And adenocarcinoma compared to SCC is more common in the Northern Europe, Northern America, and Oceania than in other regions. So we have these layers. We can just revise them: epithelial, lamina propria, muscularis propria. They form the mucosa, whereas you have submucosa, muscularis propria, and adventitia. For the risk factors for squamous cell carcinoma, age, patient having higher age, smoking more common in males than females, tobacco chewing, and alcohol all contribute to squamous, whereas GERD, reflux disease, or an obesity can predominantly cause an adenocarcinoma type of an esophageal cancers. And India, it's the fifth most common, and we have approximately 70,000 new cases, and with a prevalence of again, 70,000. So coming to the biomarker testing, it is recommended that you need to check it PDL1 and MSI by PCR or MMR by IC in locally advanced, recurrent, or metastatic esophageal or G junction cancers and are candidate for treatment for PD-1 inhibitors. And NCCN recommend testing for the HER2 overexpression in patients with inoperable, locally advanced, recurrent, or metastatic adenocarcinoma, esophagus, or G junction for whom trastuzumab is being considered. So yeah, the house says for adeno you do check HER2. For squamous, you don't check HER2. Rest markers remains the same. PDL1, you can go at MSI by either by the PCR or MMR by the IHC. Any of them can work because they have a 99% sensitivity specificity. So both these tests are in themselves a benchmark while defining microsatellite instability or mismatch repair proteins loss. And coming to just the definition of CPS, you need to have tumor cells, lymphocytes, and macrophages, and you have to find out the PD-L1 stating divided by the total number of viable tumor cells. And that is how your CPS is calculated. You just involve all the immune cells like lymphocytes and macrophages. That's why it is combined positive score rather than the TPS, which only focuses on the tumor cells. And everywhere, I think we are using CPS now, except for the lung. Sooner, I think we'll change that as well. So, IO with chemo versus chemo as first line therapy in patients with advanced esophageal cancer. Now, this was phase 3 Keynote 590 trial. Again, a phase 3 double blind randomized placebo control where Keytruda in combination with the CIS5FU versus placebo CIS5FU was given, and the eligibility criteria were same just we discussed, and the treatment naive ECOG status 0 or 1, and the measurements were done by RACES 1.1. Histology, you have a squamous cell versus adeno. So I think stratification factors were more or less towards the favorable subgroup of the patients. And how did they divide it? They said that you use Keytruda 200 mg 3 weekly plus chemo, where cisplatin was given 3 weekly, and 5FU for day 1, 2, 3, 4, and 5 was given 3 weekly. This is the challenging task over here. Whenever you are trying to give such a regime to our Indian patients, 5 day admission, they go bonkers over hearing that dog, you'll be admitting me for 5 days. So every institute has their own institutional way of practicing and combining the immuno, especially Keytruda with the 5FU cis regime. Now the dual primary endpoints were there. They wanted to know about the OS and the PFS. If we were to see the baseline characteristics, they were well matched, and males were 82%, Asian patients were 52, mostly were having PS1. Unresectable were only 7%. You can see that more than 90% constituted metastatic disease, and 73% constituted squamous cell, followed by 26% adeno, and that's how you keep on going down the lane. And what about the CPS score? More than 10 in 50% of the patients. So Keynote 590 OS for Keytruda plus CIS5FU plus placebo or CIS5FU in the CPS of more than 10, 38% reduction in the risk of death with the Keytruda with the CPS of more than 10. So you can just see at the end of 2 years, you have a delta of approximately 15% and a median OS benefit of 4 months. What about the patients where we are going to look for the OS? Just a second. So this was the OS, and this slide is of the. Now this is a select subgroup where only esophageal squamous cell carcinoma patients were taken into the calculation. Again, they said that 43% reduction in the risk of death with Keytruda with CIS and 5FU. Now coming on to the PFS, you have a hazard of 0.59, and look at 18 months. You can have 21% vis-a-vis only 5% and the median PFS benefit of not more than 2 to 3 months. So, Keytruda is only indicated in esophageal cancer in adult whose tumor express CPS more than 10. And you can just see for patients with CPS less than 10, it is touching the line of unity. For more than 10, it is way significant with the hazards of 0.51. And the limitation of the 590 was that it was not powered to detect the difference in the treatment effect in these subgroups. So obviously with every subgroup analysis, this is the same old answer that we have been giving to each other. You can definitely make a forest plot, but the interpretation of the forest plot depends upon the consultant who is seeing it. So what about the ORR and DOR for Keytruda plus CIS5FU? You can see ORR to the tunes of 45% vis-a-vis only 30%. So again, a 15% benefit, and duration of response, a massive 38.6 month, which is something really fantastic. And what about patients with PDL1 or a CPS more than 10? There it was 51% as compared to only 27%. CR was there in double the patients. From 2.5, it was to the 6%. And duration of response again 10.4 months. And what about the adverse events in ITT population? I think there was no major signal, or the daily routine side effects were there. Obviously, you are bound to have more immune related adverse events, but there was no new major safety signal observed in this. So we'll be concluding here that Keytruda plus Cis5FU was compared with the placebo and Cis5FU as a first line, and obviously it did better. And patients with CPS of more than 10, you have just seen how much benefit it has done. And the safety profile reported that both are comparable. There was no new safety signals. And that's why you have it in your guidelines having bifurcation with the HER2 positive and a HER2 negative. And in patients with you have HER2 negative, you can combine with Keytruda. But I think this is the old recommendation. You do have the approval from the newer trial where Keytruda has been combined with the trastuzumab with the 5FU based regime. So because this was the topic given to me, I had to discuss this only. And that's why Keytruda, along with the combination with the platinum and 5FU based chemotherapy, is indicated for the first line treatment in locally advanced unresectable or metastatic carcinoma of esophagus or HER2 negative G junction adenocarcinoma, where patient CPS is more than 10. Thank you.
Thank you so much, Dr. Aditya. Since you were talking about long admissions with 5FU and cisplatin, uh, do you routinely think that changing with Pacti-Carbo, although no data, no good data, but is it a practical good
So,
option
you
for?
know, generally I don't change the 5FU backbone. I stick to 5FU, but I try to give 5FU via pump. So I use, I use two pumps. So patient comes on day one, and again, they change their pump on the day three. That's how I, switch it. But chemo backbone and the salt remains the same. I generally don't switch. I reserve Pacli Carbo for second line somehow. I've been very comfortable in saving Pacli Carbo for the second line, because if you give it in the first line, I think hardly any patients tolerate such an aggressive regime.
Yeah, I totally agree with that, and I think the that's how the sequencing is standard. But there are some patients, odd patients, who are not very fit for 5FU based combinations, and I think weekly Pacli Carbo in that kind of
So
patients
for them,
plus minus
what you
IO with
can
that.
do is start them on Keytruda along with cisplatin, a low dose that we use 30 or 40 mg, and just start with the tablet capecitabine, which is dissolvable. And as soon as you get a response and you tell your patient, now we'll be shifting you onto the IV medication, that way at least you are still maintaining the sanctity of the protocol. Obviously, the practice varies from institute to institute. So this way, I have been able to comfortably pull out so many of the patients. But if you are comfortable with Pacli Carbo, I think that's the way to go ahead.
I think the we have long data follow up with a 5FU based regimen. So I
Yeah.
think it's more practical and sensible to
You can
switch to
technically extrapolate from the breast
capacitably.
cancer, right? You can combine Pacli Carbo with trastuzumab. Nobody's going to challenge that.
Yeah.
So yeah, that
So
is,
thank you, Dr.
everybody
Aditya.
uses their own concoction. Yeah.
Yes. Uh, Thank you so much.
Yeah.
So moving on, we'll be now discussing about one of the rare entities in colon cancers, that is BRAF mutations in metastatic colon cancers. And for that, we have with us Dr. Jagdeep Singh sir. He's a senior medical oncologist at AI Hospital Amritsar. Hello, sir. Welcome you.
Hi, Ankit,
And
how are
over
you?
to you. I'm good,
Thank you
sir.
so
How are
much.
you?
Fine, fine. So I was just listening to what Dr. Aditya was saying. So in my practice, if you ask me, I usually don't give 5FU base because uh, usually cisplatin I don't combine becomes a more toxic and patient may not be able to tolerate usually. And Folfox and Pembro, there will be two visits for patient, one on 2 weekly, one on 3 weekly. I usually give Capox, that is more easy for me, and patient can come on a single day for the same. This is what I practice.
No, absolutely correct, sir. Uh, these things vary from personal experiences, and I think we become more uh, like used to some kind of drugs, although the data is more or less same, even if we look without the IO, comparing the Folfox or cisplatin
And
5-FU, or
I'm
so it's more about.
more switched towards the nivolumab in case of squamous cell, like rather than giving pembro, because patient can come on bi-weekly. That is more easy for me to give, and on the same day patient will go for the Folfox and for the nivolumab. So for patient to get off the pump, I usually ask to contact a local hospital and they can be in touch with us. So this is
So
how
I
I.
think the patient selection, the patient profile, the
Yes.
side effect profile, and how good the patient is going to tolerate a one particular drug is the key to select that.
Yes, yes. So, and moreover, what Dr. Pankaj was discussing about the CPS, I think is a more precise way to defend to use IU rather than going for TPS. So this is like when you are talking of the CPS and taking all the immune cells in the microenvironment. So we're talking of the whole of the microenvironment. So it may be more dictating, and it will be more, you can say, pushing us with that data towards the IU rather than for the TPS. This is how I feel
Yeah.
with with CPS.
Yes, totally agree, sir.
So anyhow, thank you for giving me this opportunity to have a talk in this metastatic CRC, and I'm going to discuss one of the lesser common mutation, that's a BRAF. So is my slide in the presentation mode and is moving?
Yes, sir. Visible
Yeah.
moving.
Thank you so much. So my assigned talk is for the BRAF mutation in metastatic colon cancer. So CRC is a very heterogeneous disease and lot of mutations are there. But if you see with all the genomic transcription, so approximately 45 patients or close to 35 to 40 patient of the are having RAS mutation. And 26 patient they are having wild type RAS, and very few patient had other mutations, maybe in the form of like BRAF and MSI or other like HER2 mutations. So if you see, majority will be with the RAS mutations. So as per the major guidelines, NCCN and other guidelines, they all recommend the patient should be tested for the KRAS, NRAS, BRAF, and the MSI in the patient with a metastatic CA colon. So of course, when we are talking with for the MSI, so you do any of the thing, either you go with the MMR or you go with the MSI with the NGS based. So both have a good concordance rate with each other and anything can be used, but there are still some of the patient which can be still missed with the MMR, which we can pick with the NGS. So sometime if you feel that a patient needs to do go NGS, you might ask that after doing a MMR in patient. So of course, this MMR or MSI is recommended for all newly diagnosed CRC, and it should be done in approved laboratories, and it should be completed by PCR or validated NGS panel. And ISC again, which I told that is for the 4 MMR gene, that is the 4 MLH1, MSH2, MS6, and PMS2. And if you have MLH1, you have to think about the BRAF mutation or the promoter methylation for the MLH1. And if this BRAF mutation is present, then you have to think that it's not something linked with the family, it's more like a sporadic cancer. So these are the major drivers, that's the tumor characteristics, patient features, or the treatment considerations. So you have to take all the things into consideration while not planning a treatment for patients. And all these things are basically equally adding towards the patient's outcomes. So this is very common. Everybody knows that patient with the RAS mutation do not respond to anti-EGFR, and the BRAF V0600E mutation responds very poorly to the anti-EGFR agents unless given with the BRAF inhibitors. So this is one of the most important thing, that is the right side versus left side, and we know the right side behave poorly as compared to the left side, though the right side is having more high MSI, but still it has a poor outcome as compared to the left side. There are some other features for the right sided, that is they are more of BRAF mutation and they lack of benefit with anti-EGFR therapy, but there are now some of the coming data in which we can use anti-EGF therapy in even in the right sided without any mutations. So this is how we choose a treatment therapy, either for the right hemicolon or the left hemicolon based on the mutation and status, that is whether it's a RAS mutant or RAS wild type. So again, doublet versus triplet, a lot of debate, and I think patient with a doublet, they do fairly well. Of course, a young healthy patient triplet can be given with some of the challenges with the toxicity, but usually we prefer a doublet chemotherapy. So between 18 to 12% of patients with the metastatic CRC, they have a BRAF mutations, and they have a poor outcome to the standard chemotherapy and very poor dismal outcome, survival. And approximately 30% of these are BRAF mutated CRC have a MSI, and transcriptomic signature suggests a strong immunogenic biological background for the majority of these tumors. So what was the standard of treatment for this BRAF mutated MCRC before we have this BRAF inhibitors with us? So usually we give any sort of doublet or triplet, and it's combined with the anti-VEGF, because anti-EGF usually don't give any good outcomes for these. And post hoc subgroup analysis with the triplet plus bevacizumab, they appeared more active than the doublet plus bevacizumab, with the overall survival 19 months versus 10.7 months. So, but again, meta-analysis failed to show the benefit of this triplet chemotherapy in these patients, and we have a lot of other trials which it was used in second-line therapy with the patient with the BRAF mutation or other. So there were a lot of questions, but we don't have an exact answer till the time we have this Beacon trial with us. So you can see there are two different pathways. So one is this RAS, RAF, MEK, ERK pathway, and other is a PIK3 mTOR pathway. So we are supposed to target the downline stream target, and if we target only RAF inhibitors, still we might not be able to get the exact, because there are some of the escape mechanism due to which the down regulator pathway still get activated. So this Beacon's phase, this study was a phase 3 trial of this encofarinib with the cetuximab with or by for the metastatic CRC with the patient having BRAF V600E mutations. So of course, the patient with a good performance status and the BRAF mutation in either the previous determined by local assay at any time or by the central laboratory, and the patient were randomized to this triple drug combination, that's encorafenib plus bendamustine plus cetuximab, or cetuximab plus encorafenib, or cetuximab and chemotherapy backbone. And the primary endpoint was the overall response rate and the overall survival, comparing the triplet to the control arm. So if you see the PFS with the triplet, it is 4.3 months versus 1.5 months. So they have shown that hazard ratio is 0.38, but it behaves very poorly, as we all know, the BF mutated, but still, so it showed that it was statistically significant. So if we compare the doublet, that is a cetuximab plus encorafenib, it was again doing better with the control, that is the cetuximab plus chemotherapy, as compared with the doublet. So either we use a triplet or doublet, that's going to do some better as compared to the cetuximab plus chemotherapy. So if we go with the overall survival or the overall response rate, you see the patient who received this triplet of this encorafenib, cetuximab, binimetinib. So the overall confirmed response rate was 26%. In the doublet, it was close to 20%, and the patient who were receiving this chemotherapy plus cetuximab, that was 2%. So that was a poorly low. Similarly, we take into consideration the median overall survival. It was 9 months with the triplet, 8.4 months with the doublet, and 5.4 months with the chemotherapy plus cetuximab. So this phase 3 Beacon trial showed that the triplet regimen with the encorafenib plus biminitinib and cetuximab, and the doublet regimen with the encorafenib and cetuximab led to the significant improvement of this overall survival and a response rate as compared to the standard of care in the previously treated patient with the BRAF mutation, because these patients have received at least 1 or 2 lines of chemotherapy prior going to for this triplet. So median overall survival was 9 months with the triplet, with 8.4 months with the doublet and 5.4 with the control arm. So no new safety signals were observed, and investigator concluded that results support a combination treatment with the BRAF, MEK, and EGF inhibitor as a new standard of care with patient with a BRAF mutant metastatic CRC. So another trial in the BRAF mutation in the first line, this was Anchor CRC, and this was phase 2 study. And basically it was 2 stage. In the first stage, 40 patients were enrolled and the triplet was given. And in the second stage, again, 50 patients were enrolled, and this triplet was given. And treatments continued until the disease progression. And again, the primary objective endpoint was the overall response rate in the patient with the combined at stage 1 and 2. And the secondary endpoint was the PFS and the overall survival with a safety analysis. So among these patients, that is a 95 patients who received this triplet, the overall response rate was close to 47%, and stable disease was observed in the 41%, yielding a disease control rate of 88%. So with the median follow-up 20 months, the median PFS was 5.8 months and the median OS was 18.1. So these triplet was well tolerated with new unexpected toxicity, and most commonly with what we have seen with the grade 3 or more events were anemia or diarrhea and nausea. And with the biotin, usually we have some sort of the eye problems, that's the retinopathies. So this was a phase 3 trial of this encorafenib plus cetuximab plus chemotherapy for the BRAF metastatic CRC. So a background of this study is because, as we all know, that a patient who have the BRAF mutation, but they have a limited efficacy with the treatment with the chemotherapy and the cetuximab, and a poor outcome. And based on what the Beacon studies showed, that in the first, in the more than 1 or 2 lines of treatment, this triplet had showed a benefit. So this combination of encorafenib plus cetuximab were approved in the previously treated patients in the BRAF mutated CRC. So now the first line treatment option remains an unmet need for patient with the BRAF mutated MCRC. And this phase 2 anchor study, which has showed our response at 47% with median PFS of 5.8 months. This led to this backwater study. And again, we have to see whether the first line is going to do better in these patients which have a poor outcome. So building on this first line results, this was an open label global multi-center phase 3 breakwater study, and it was evaluating the first line encorafenib plus cetuximab plus chemotherapy with standard of chemotherapy alone in patient with the BRAF mutated metastatic CRC. So you can see there are 3 arms: doublet plus chemotherapy, and doublet plus, that is doublet chemotherapy plus bevacizumab. So they have seen that patient whether we can give this FOLFOX or FOLFIRI, and it was based on the safety led one analysis that FOLFOX would be better as compared to the FOLFIRI. So this was the baseline characteristic which were well matched in all the patients. So approximately you can see all the patients, they have a presence of liver metastasis in close to 37% patient with the EC plus FOLFOX. And again, with this was a safety led one. This was a basically initial trial which led to the approval of this doublet plus chemotherapy. So you can see the patient who received FOLFIRI or FOLFOX, they were approximately higher with those patients who were having this liver metastasis in the FOLFIRI arm. So if you see the overall responses, this doublet plus FOLFOX, the overall response rate was close to 68%. If you see with the FOLFIRI, it was 66%. And patient in the second line, FOLFOX showed a 50% and FOLFIRI showed a 61%. So approximately responders in the patient median time to response, you see 6.9 months in the patient who with the first line FOLFOX, 6.6 with the FOLFIRI, and again the second line was 9.4 and 12.9 months. So if you go PFS by the investigator, patient who received the first line doublet plus FOLFOX, median PFS was 9.9 months. With the FOLFIRI, it was close to, it was not estimated. In the second line FOLFOX is 9.7 months, and in the second line also FOLFIRI, it was not estimated. So this doublet of that's encorafenib plus cetuximab and plus chemotherapy was generally tolerated without new safety signals. And it has been seen that patient who receive FOLFOX, the steady state encorafenib did not, this concentration does not alter the oxaliplatin exposures. But with the FOLFIRI, what happens? The level of iron taken decreases by 25% and we have a less outcomes. That's why FOLFOX is better going to do with the EC. So it was chosen in the phase 3 trial. So preliminarily promising anti-tumor activity is seen in the patient receiving this EC plus FOLFOX or FOLFIRI as a first or second line therapy for the BRAF mutated metastatic CRC. And these results are particularly encouraging when compared with the historical results of first line chemotherapy for the same BRAF mutated metastatic CRC. And data support that the ongoing this BAKE3 water study, in which this doublet of encorafenib and cetuximab and Malfag was chosen partly based on this pharmacokinetic interaction between the encorafenib and oxaliplatin. So this was a major study. We have to get the results, but we now talking about the real world first line treatment patient with the BRAF mutated and metastatic CRC. That's the CAPSTAN CRC studies. So this was a retrospective multicenter observation study in the Europe in patient who were metastatic CRC and with the BRAF mutation. And it was the largest observation study and that collected the real world data to describe the baseline features and patterns and effectiveness with the patient with the metastatic CRC with BRAF mutations. So not going to detail of this table. So the patient who received this doublet or doublet plus triplet chemotherapy or cetuximab, you can see the median PFS was close to 4.3 months to maximum 6.6 months. So similarly, the median overall survival was again 12.8 months in the total patient population, and it was with the chemotherapy and doublet or triplet, it was 11.6 months. So again, with the targeted, it was 12.8 months, and triplet plus target is 13.1 months. So it has shown that patient who received this BRAF mutation inhibitors, they have a better as compared to the patient who was receiving only chemotherapy doublet or triplet. So this BRAF mutation is a biomarker for prognosis as well as a treatment response, and screening is recommended in combination with the RAS and MMR or MIC determination. This CAPSTAN CRC study helps to elucidate the real-world European management of this BRAF mutated MRC CRC, demonstrating the aggressiveness of disease where the median OS was 12.9 months and only approximately close to 52% patients were able to receive a potentially effective second line. The study's finding highlight the importance of testing this BRAF mutation to personalize and optimize treatment, and the close monitoring is necessary for patient with the mutational study. So this is the recommendation for the BRAF mutation. Now we have the patient with a metastatic CRC with the BRAF mutation. First line is a chemo doublet or bevacizumab or chemo triplet with the bevacizumab. In the second line setting, we can go with the cetuximab or encorafenib doublet or can combine with the bimitinib. This is what we have right now. But with the breakwater, that is phase study, we might get this in the first line setting also. So these are the main studies of Breakwater 3, which is a phase 3 and which will answer our questions that whether this is first line is going to be effective in these patients which have a poor outcome. So thank you for your patience listening. So now it's open for discussion. So any questions, I welcome.
Thank you so much, sir. If anyone has any question, maybe you can ask. I think, sir, with the molecular testing increasing in the last 1 decade, these entities are becoming more common. And not only V600E, now we are picking up more BRAF non V600E. So that is also
Yes.
one of the domain where progress is
So
coming.
when
And
we are going to the details of more exon level of elucidation of the other points, so we might get some more of uncommon mutations, and for which the data may not be sufficient to support any targeted based treatment. So sometimes we have to extrapolate based on the what we have with us.
yes, agree, sir. So moving on, we'll be having a small case-based panel discussion. Uh, just a second. Yeah. Is my screen visible?
Yes, sir. Make it full screen, please.
Yes. So maybe I can request Jagdeep sir also if he has time to stay back and interact with this panel discussion as well.
Jagdeep sir
So,
is left, sir.
okay. So do we have all the panelists? Bhavesh sir is here. I can see
Yeah, Bhavesh
Shala,
sir is there,
Rajat
Dr.
sir.
Rajiv is there, Dr. Deepak Bharti sir, Dr. Shalabh sir, and Dr. Syed Nisar sir. Both are there.
Okay, so all are here. Okay, okay, that's great. So very good evening, everyone. And this I have made this case-based presentation, but we'll be focusing on the core competencies on the management of metastatic CRC. And I have a second case, if the time permits, on HER2 new in CRC. So just as the case, a 49-year-old male presented with anemia, and on evaluation was found to have a sol in the liver, which was further worked up, and his imaging showed a nodular lesion in the right middle lobe of a lung and multiple liver lesions in segment 4A, 7, 5, and 6, and a concentric thickening in sigmoid colon. So his colonoscopy was done, and a transverse colon polyp and a large ulcerated sigmoid colon mass was seen. So further, he was evaluated with the CE, MRI, and PET CT, and FNAC from the liver showed metastatic adenocarcinoma, and a sigmoid biopsy showed moderately differentiated adenocarcinoma. So it's a case of metastatic sigmoid colon, moderately differentiated adenocarcinoma with liver mets in bilobar liver mets and a solitary lung met. So maybe I can start with Bhavesh sir. Sir, how would you like to approach this case, and in your clinical practice, how do you evaluate further?
So, first and the foremost thing is we'll do two things simultaneously. One is an MDT, that's a multidisciplinary team decision, whether this is going to be in any point, any time in future, operable or inoperable. Number one. Number two, we have to simultaneously send for, if possible, a CGP on the biopsy, or else at least a focus panel where we see specific markers like HER2 neu, PDL1, MSI-H, BRAF, KRAS. These are specific markers which we'll be seeing in all kind of metastatic CRC patient. So then we'll take it further according to that.
Yeah. So the very important crux which Dr. Bhavesh told, that MDT is the key. And even if it is involving bilateral lobes of the liver and single met in the lung, I think involving the surgeon upfront and the interventional radiologist for any local ablative therapy later on is very, very important. So I'll ask Sayed sir. Sir, what is your take on the molecular workup CGP versus a broader panel NGS or a hotspot testing?
Yeah, good evening.
Considering that there are no financial constraints.
I think a broader panel is what is the way forward. Because there's always an issue with like what we call as negative hyperselectivity. So sometimes the presence or absence of other co-biomarker may influence our treatment with the first presence of a biomarker. So that is important, and there are now new biomarkers which although are rare, but they can have, and we have sometimes started like we have NTRK, like now food is coming, POL-D is coming. I think it's, affordability is not an issue, and the finances are not an issue. We should do an NGS basis, a broader panel.
Yes, sir. So I totally agree that finding rare mutations like NTRK, RET, and other few will keep on increasing once we increase our testing. And switching towards CGPs or a broader panel NGS is the way forward. So with this era of precision oncology, now we can conclude that over the last 1 decade, we have seen so many changes, and we can see that clearly see that metastatic CRC is not a single entity, not a single disease. And with the availability of the genomic profiling, we can subclassify into various other factors, and the treatment also varies. So maybe in the second line itself, but yes, the progress is there, and we are now shifting the gears towards the precision and the personalized treatment. So moving on with the case, the molecular profiling was done, and it's a KRAS mutated, NRAF, BRAF negative, MSI low, HER2 negative, and PDL1 22%. So Dr. Shalab, uh, Bhavesh sir told that yes, PDL1 should also be sent. But in this current scenario, most of the immunotherapies are like approved only for MSI
MSI-H.
high colon cancers. So what's your take on this PDL1?
I think PDL1 per se in any indication, not only in colorectal cancer, in any other indication also, it's far from ideal biomarker. Like ideally, I would want something like ERPR or HER2, which would give me a categorical answer whether I should give the patient that therapy or not. And PDL1 is doesn't. I mean, even a negative, you can find PDL1 zero responding to IO, whereas you find patients with PDL1 90% not responding. So I wouldn't base my decision on PDL1 in this scenario, at least as of now. Yeah, definitely if the patient had MSI high or a high TMB, then I would prefer IO. But in this setting, I think I would bank on this KRAS positivity and base my decision on this alone.
Maybe I agree with you that even I don't want to fiddle with the treatment in the first line. But suppose a similar scenario in the second line, no other targeted end. So MSI, say MSI stable and PDL1 is high. So in that case, would you rely on that and add
Still,
immunotherapy?
still, I think PDL1. If I have run out of options, then maybe I would rely on PDL1. But otherwise, it's a very unreliable biomarker.
Okay. So this was the final diagnosis. And next is like a controversial thing to discuss. We have been discussing this last few years and no consensus. So maybe Dr. Rajiv sir can take on this. Do you routinely counsel your patient for DPT testing in metastatic setting?
No, we don't give routine counseling for DPT testing. But in the front case, the case upfront, it's a classical left-sided KRAS mutated, and as conventionally we had been putting on use of bevacizumab plus either of the arm of the chemotherapy doublet. That's a classical setting. So that will be the treatment option I'll be exploring in such patients.
Okay. Anyone else is like using DPT on a regular basis or all
Okay.
agree with the
No, no. So good evening, Dr. Deepak here. So there are two
yes,
things. Uh, as the data DPT is there, and I think we should use that because just for our routine knowledge, that how many patients are coming DPT positive, just our we have the base that how many populations are positively there, and it is there. If you have to tell the patient, because if something will get patient get grade 3 or grade 4 toxicity because of IFU based chemotherapy, because it's very easy for us to make them aware that this thing can happen, and later on it's all depend on the patient that whether they want to choose it or not. But whenever we are starting the patient or anything, we should discuss this thing with the patient.
So,
so
Dr. Bhavesh here, I also agree with what Dr. Deepak said that it has to be offered to every patient who is on any kind of 5FU or a 5FU based therapy, because the percentage, whatever has been seen across India in a single institute or a small series, it is not in single digits, it is in double digit. Moreover, either hetero or homozygous, whatever it is, if we find even one allele drop or two allele drop, we have to consider for reduction in the dose to as low as even 50% or even sometime 25% in practice. So because these patients are very sensitive, if you want to use capecitabine as a backbone, we may even lose this patient if a full dose of 5FU goes inside because there is no other way to stop it now. Only if it is in capecitabine, at least we can, salvage the patient by stopping the therapy and support the patient. But if 5FU goes inside, you have 2 weeks to tackle. I mean, it will be very difficult to take the patient out.
yes, sir, I totally agree with you. And even I also believe that it should be offered to all the patients, although I'm not pushing it very much in the metastatic setting. We just have a shared informed decision with our patients. But definitely in adjuvant settings, especially in stage 2 and stage 3 colon, or in TNBC where we are offering adjuvant capecitabine, in that cases, I make sure that DPD is done because I've seen one case where I've lost the patient just with a single dose of capecitabine.
Oh my God.
So moving on, so in these kind of scenario, how confident or how comfortable you are discussing the role of surgeries with your surgeon? Uh, maybe we can discuss with Syed sir. Uh, like, do you consider them on their own, or you discuss with your surgeons in the MDT and how easy it's for you to convince your surgeons in such kind of scenarios to discuss for and consider for, or maybe uh, not to rule out surgery at all.
So we should always discuss, and we at our institute as well discuss all cases like this in MDT. So basically, we need to have medical oncologists at this surgical oncologist and including intervention radiology. So we do discuss. So uh, of course, we assess the situation, age, comorbidity, what is the understanding of the family as well as the patient. Then so upfront, say unresectable, borderline resectable, we can say like totally unresectable diffuse metastasis. They then go on with the medical oncology only. But otherwise, like borderline, or sometimes even we may say after, let us give 2 to 3 months of chemo is targeted, and then image and rediscuss the case. Maybe they are converted into resectable stage, or we can use multimodal treatments at that point of time. So we do discuss, and they have to be discussed, including all these people. We have to take them on board.
Anyone in the panel is propellant for colonic stenting, uh, be it due to any reason, if the patient refuses for colectomy or the colectomy is not feasible due to any other reasons. So, do you consider colonic stenting and in these kind of patients, or you try to avoid that?
I think in sigmoid colon, you can still try because if the patient comes with obstruction and because of any reason you can't take the patient for surgery, because surgery or diversion colostomy is the easiest to do. If even patient is not fit for that, then probably in a sigmoid colon, colonic stenting is a good option.
Yeah, so you're not shying away from that option as a physician in charge of that patient.
Definitely. Because that is a that is many times that is a symptom with which patient will come alternating diarrhea and constipation. So it will also give relief in that symptom.
Yes, yeah. So, Rajesh sir, you were telling about like doublet chemotherapy and adding bevacizumab. Suppose the surgeons feels or our team MDT feels that NACT should be given and then reassess for a curative intent surgery. In that case, you still would like to go ahead with bevacizumab, or you would like to think about the triplet chemotherapy?
First of all, if I consider this case, I don't feel that many surgeons will be opting for a surgical option with a multiple liver SOLs and even lung metastasis. Even if let's assume that a surgeon takes up the challenge, in that case, I would take a BEV for better response, but I would try to stop use of bevacizumab about 6 to 8 weeks before planning a surgery. That is the first option. This I'll think.
So in between like triplet chemotherapy and using a BEV and stopping 6 to 8 weeks, you would prefer doublet plus BEV and stopping at 6 to 8 weeks.
Stopping it before that.
Uh, Dr. Deepak, your review on that? Dr. Deepak is here.
Dr. Bhavesh here, I'll just like to comment here that in case if this was in the left lobe of liver, all the metastatic sites, all the lesions in the liver, and there is one solitary lung met, and then there is a colon, then this is very, very lucrative for, going for a curative intent kind of a therapy where we do want to see a in situ response. So where we will give chemotherapy plus minus targeted therapies to get the maximum responses and take this patient for a curative intent treatment, either in the form of surgery or surgery plus radiofrequency ablation. Means multiple combinations can be done, but this patient should be focused for a curative intent treatment where we can understand that just taking a left liver lobe out, one lobe in the lung and the colon and the nodes, and the patient is curative intent. So that should be the focus of the MDT.
So the point here is, sir, that borderline patients whom we are not very sure whether they will be able to be converted into a surgery or not, and the dilemma of using bevacizumab, whether to use them or the fear of missing out if we are not able to convert them for surgery, then we are missing on the targeted therapy. So that is the question here, which we see in most of our clinical practice. The borderline patient, even the surgeon thinks that yes, we will reassess later. As of now, we are not very sure. So in those cases, I think it's difficult to decide, and that is the area where we need to know the individual experiences of the centers, how they are tackling whether triplet chemotherapy or bevacizumab, what is better. I know we are not going to get any study, be it retrospective on that. So it's all about individual experiences and institute experiences. But I think, yes, both the ways are good. If the surgeon is confident enough, then I think uh, in that case, both the options are valid of using bevacizumab in addition to chemotherapy and stopping it 6 to 8 weeks. And it also depends on the patient profile as well.
Absolutely. So I
So,
totally agree with all the points because this will be an individual decision. And mainly, as you said, that if it is upfront multiple metastasis bilobar in the liver, definitely even this patient responds nicely. Nobody will operate on this patient because we know
so
that this patient is going to come back with again a new lesion in the liver again.
Yeah. So
So
Dr. Shalab, when you are practicing in your region, when I know the surgical support there is limited. So in that kind of scenario, what is your preference?
So I think over here it's not very gray. It is, most surgeons won't operate on this particular case, and I would start with neoadjuvant chemotherapy. And again, both the options are there: triplet versus doublet plus Bev. I would rather stick to a triplet in this case because the best responses are seen with either triplets or I think with doublet in combination with EGFR inhibitor, which we can't give in this case.
Yes, yes,
So
I totally agree.
over Bev, over doublet plus Bev, I would stick to triplet.
Triplet. So this patient also received neoadjuvant chemotherapy, first cycle FOLFIRI and then 3 cycles FOLFIRINOX, and got a very good partial response. He underwent surgery. Uh, the surgery extent needs to be again discussed, whether it be stage surgery. In this case, it was a bilateral liver, so definitely it's going to be a uh, stage surgery, and then followed by continuation of the systemic therapy with or without surgery is also an option. So this patient underwent an LAR and a liver mastectomy and VATS pulmonary metastatectomy, and it came out to be YPT2N0. The lung mets was totally necrotic, and the liver was necrotic with few viable tumor cells. And further, the chemotherapy was continued in the similar fashion. And after completing this chemotherapy, when we know that few of the liver lesions had viable tissue, and it's a very good response to chemotherapy. So, how would you like to take this case further? Maybe I would request Dr. Rajiv sir to take on this.
So first of all, I would congratulate such a energetic and daring surgeon who has done it. And suppose there are viable cells, I would put the patient on capecitabine for a maintenance treatment in such patients, single agent.
Okay. So, Bhavesh sir, any role of would you like to consider ctDNA here?
I think definitely this is a stage for metastatic CRC to begin with. Here is, I mean, whatever ctDNA role is being studied is maximum in this scenario where you will be more confident with the, corroborative or the comparative responses. So definitely ctDNA should be done in this patient. And in fact, here, if at the end of therapy, if the ctDNA is zero, then probably these patients even can be kept on observation and a follow-up of ctDNA because you have completed around 6 months of therapy with the R0 resection. This patient, we expect that they are going to do good if ctDNA is negative.
So, the liver resection was done only in one lobe, and the other lobe is still having some lesions which are not petavid. So, maybe if Dr. Deepak is here.
Yes. So there are
Yeah.
two things regarding the routine scenario. What we have followed are things. Dr. Vesh is truly saying that we have to do the ctDNA because it's the need of the hour, and the data has come with colon cancer only. So we can do ctDNA sequentially or with a follow-up reassessment with the imaging, with the addition of imaging. And regarding the other point, what you are talking about, that some FDG non-AV lesions are still present in the liver. I think multiphasic MRI can give an answer to that thing also, that whether they are metastatic or not, and we can proceed further.
So for ctDNA, one is theoretical aspect, everyone wants to use that. But like practically, is anyone using in their routine practice? And if yes, what platform or which lab they are using?
So
Any
that's a,
experience on that?
basically at our center still not we are not sorted the things, but I'm just saying that what science says that we should do that, but at present we are not ability of that thing is not with us, and in future is something we will definitely do that.
Rajiv sir, you are using ctDNA?
No, I'm not using circulating DNA, but since we could get some viable cells, and I'm sure that possibly in coming few months or in coming few weeks, more and more lesions may come up. Henceforth, that's why I was in a favor that some sort of maintenance treatment should be given instead
Yes,
of wait and watch.
yes. No, I totally agree with that. Uh, Anyone else using ctDNA and their experience with that? Sayed sir, Bhavesh sir.
Not really. We do counsel, but most of the patient don't agree for that because we
We
have to
have
tell them this is going to be like repeated every 2 monthly or 3 monthly.
Yeah, so this was the ctDNA report. It was around 500 prior to the at the diagnosis, and it post surgery it became less than one. And after the completion of chemo, as I told that liver
can I
lesions were not FDG. Yes, sir. Please go ahead.
sorry to interrupt. So we have used it in additional cases in a few patients. One thing is that the lesions which were usually active on left side, so basically we have to address those as well. So simple PET negative doesn't mean that we cannot have a disease on histopathology. So we have to address those as well. So those are active pre uh, chemo and pre-surgery. So because we have to take all the lesions which are active. Secondly, that therapeutic chemo, we can then of course addressing those liver lesions, maybe with different ability techniques. So then we can maintain capturing the liver BCR, liver capturing. Of course, if ctDNA is negative, we can follow.
That
Batra,
I think there's some network issue at Dr. Ankit's end.
hmm. But
once till the
just till the time we get him back, just wanted to ask like if there is a response like this in practice, how comfortable you are keeping the patient on observation, like ctDNA is zero, there is nothing on the PET scan, patient has undergone a good surgery, whatever visible disease was there has been removed. Are you comfortable keeping patient on observation, or as Dr. Rajiv said that obviously we are all always worried that this patient is going to come back with disease, but with the confidence of ctDNA being zero, will that add to our decision that we should keep this patient on observation rather than start maintenance treatment? Dr. Salab, you can comment and then we can take opinion from all the panelists.
I think this since this patient was RAS mutated, I would prefer to keep the patient on some form of maintenance rather than just rely on that ctDNA report. That would be my take.
Dr. Deepak,
Same here, sir. Definitely, we have to give capital maintenance in any sort, because we know some sort of lesions still left behind. Even if it will be a R0 section or no disease will be there, still I want to give some sort of maintenance treatment at this point of time also.
So the usual NCCN guideline, what it says that you can stop therapy if you have undergone a surgery, a curative surgery has had been done, then you can still observe the patient after you finish your 6 months of therapy, peri-op therapy.
Yeah, so there are two things in that. We know that we don't able to get any OS benefit. It's just to just give the DFS or EFS benefit in that point of time. These are only more because we know that the patient disease, the routine tempo that disease have to come back. Just to line the things that with that capsaicin and other way around, patient can tolerate the things, and we can give for some 6 months or 1 year, and we can see the things. And at a point of time, we think that disease is absolutely negligible. We can take a decision to stop or take a break or some time and then decide accordingly.
I think Dr. Ankit is back. He can continue.
Yeah, sorry, sir, I missed in between. I lost connection. So maybe what I can sense was discussion was going on whether to continue maintenance or not. I think the criteria for that not giving and not getting a OS benefit was like R0 resection and NED, no evidence of disease has been obtained. Here the scenario is somewhat different where we have some morphological disease. Although these kind of patients, not every patient fit into guidelines. So the other question was any role of augmentation of the local therapy in terms of maybe using local ablation or SBRT or RFA to the liver lesions. So I think that is also one of the armamentarium which we are not using that commonly and should involve the radiation oncologist and the interventional radiologist to seek their opinion of feasibility of doing these kind of procedures is also very much required.
So here I would just put a comment that there is a recent paper where they are doing liver transplants in such patients who are having only liver disease which is left. So, and they have excellent responses. Their 40% patients are disease free. So this is a very aggressive kind of an approach where you require to have a transplant team on board, and especially patient like this, if you want to do further aggressive therapy, is to do a liver transplant in this patient.
So that sounds theoretically very sound, but practically doing a liver transplant and the cost involved as compared to the ablative therapies is definitely a challenge in our part of the world, sir. Maybe once
Definitely.
we have a longer follow-up of 5 to 10 years in these kind of patients and accessibility of liver transplant in tier 2 cities, the
Number
things
two,
might change.
there is
Absolutely.
itself a
Very, very
mortality
difficult
risk.
challenge to get a liver transplant.
So there is itself a mortality risk of some percentage with liver transplant also involved.
Yes, yes, totally agree. So I think this maintenance therapy was the challenge, and we have meta-analysis, but that is mostly in unresectable metastatic CRC. And I believe this kind of scenarios fall in between metastatic and those who have received R0 resection NAD. But practically, uh, I think the plan was meant to maintain capacitabine and serial monitoring of with imaging and ctDNA, and that's how it was managed and continuous. And the last two reports of the ctDNA was zero, and the patient is still doing good. So all these things bringing into the newer therapeutics or the newer diagnostics, including the ctDNA, involvement of the IR people and the surgeon upfront. So the crux is what Bhavesh sir has started in the first line, that MDT is the integral part of the management of even extensive metastatic CRC and for that matter any cancers. If we have time and everyone agrees, we'll just quickly see the second case of HER2 new metastatic CRC also, if everyone agrees.
Hmm. We can go a little fast on this.
Maybe just in 10 minutes we can, maybe in 5 10 minutes we can just quickly control. So we have a 54-year-old female with RAS-RAF wild-type metastatic sigmoid colon. This is a hypothetical case. This is not a real case. And she was previously treated with Folfox bevacizumab followed by Folfiri bevacizumab and developed progressive disease, and she had a HER2 ISC 3 plus. So, what would be your approach in third line of these kind of patients? We can have a quick comment from everyone, and then we'll just quickly see the 4 or 5 slides on the data. We can start with Bhavesh, sir.
I think this is a failed first line or maybe failed second line for that matter, and then third line. So we can definitely offer an anti-HER2 therapy. In today's era, we would directly go for a TDX kind of a regimen where we expect excellent response. Whether it translate into a very big survival or not, that is still a question mark. But there is a good response to therapy when a targeted agent like TDX is given in this kind of patients.
Yes, sir. So yes, sir. Apart from TDXT, if the patient is not maybe willing due to any reason, logistics, or patient is having ILD, in that case, do you use any alternative or
We had at least three patients. So we have used lapatinib and trastuzumab, and one patient had very good response. So practically we have used that. So others, like we wanted newer drugs, but they could not afford. But we found some good response with lapatinib and trastuzumab.
Rajiv, sir, your approach?
Yeah, I agree with Dr. Sayed that possibly we can use a combo of both trastuzumab and lapatinib. But I'm not sure that how strong this driver is in case of colon cancer as it is in breast cancer. So yes, we have an option to rule after two failed targeted treatment. But if patient cannot afford Drextican or TDM1, I think then safer option and cheaper option, a combo of both lapatinib and trastuzumab can be used.
Dr. Shalab, if tucatinib is available, would you like to use that with Trastu?
To be honest, I haven't managed any HER2 positive CF metastatic CRC in third line. But yeah, if tucatinib is available, I would also consider that as an option.
Okay.
But
And
TDXD would be the first thing I would choose.
first choice.
And yeah, first choice TDXD. If not, then lapatinib plus trastuzumab.
Okay. Deepak, sir?
He's left. His message that he has to leave.
Okay, okay. So, any thoughts on HER2 as a biomarker in metastatic CRC?
I think most important thing is whenever HER2 is positive, the EGFR therapy usually does not work. So I think it can be a prognostic marker, number one, and later it can be a predictive marker in the form of using an anti-HER2 therapy.
Yeah, so if we talk about prognostic, it has not changed or any differences there. If we have seen a subset analysis from the COSA trial or the focus, so HER2 strong overexpression or no expression in that both the cases, the first line treatment is still giving the same results. But in terms of predictive, yes, it's lack. There is a lack of anti-EGFR benefit in case it is a HER2 positive metastatic CRC, and we can see that in HER2 amplified, the response of cetuximab was much lesser as compared to HER2 not amplified. So this is the like response rates of trastuzumab and pertuzumab. Overall response rates in the tune of around 30%. Uh, if we talk about the KRAS status, the response rates are less in KRAS mutated patients as compared to wild. So wild type patients are doing better with the trastu pertu combinations, and we can also extrapolate that they might do better in terms of any or two targeted agent. Uh, if we talk about the Destiny CRC01 for trastuzumab deruxtecan, then we can clearly see the response rates in the tune of around 25 to 30%. And the tucatinib, the generic version might be available in 2025 in India as well. And the Mountaineer trial shows that yes, the objective response rates in the tune of 38 to 40% with the median PFS of reaching 8.2 months. So that's also a very good data because we have trastuzumab, tucatinib generic might be available in next year, and all those patients who cannot afford TDXT, so that's a very seems to be a very good alternative in that case. These are the options available. Uh, TDXT, trastuzumab, lapatinib, trastuzumab, pertuzumab. Pertuzumab TDM1 has also been tried. and then trastuzumab and tucatinib. So the best response rates have been achieved with uh, TDXT, and then trastuzumab tucatinib is also seeming to be a very good options in patients who cannot afford TDXT. So apart from these are the emerging target subset in CRC which we are upcoming and we are going to see. So that's all from my side. If anyone wants to add a final comment to this, is open to that.
Just
I
a
think you have discussed almost everything.
So we had a patient with left-sided metastatic sigmoid colon with 30 positive, RAS was wild type, so upfront, but we are hesitant in taking positivity, but we used anti-EGFR and plus FOLFOX. That patient is
It's
on
9 o'clock.
maintenance, so for last 2.5 years in CR, still going and disease free.
So I could not get you. Your voice was very feeble.
So what I wanted to convey, we had a left-sided, otherwise RAS wild type with HER2 positive colon. So upfront we used FOLFOX plus panitumab. So after 6 months, he's on maintenance for last 2 years and doing well. He's in complete metabolic remission.
So I think this was the one point I missed about his panitumab experience. So thank you, sir, for adding that. And if anyone else has also used panitumab, they can also share their experience. Okay. So thank you everyone for joining. This was all for the day one of Onco update with a focus on GI and hepatobiliary. I hope to see you all tomorrow for a discussion on hepatocellular cancers. And thank you everyone for joining for the day one. Good night, everyone.
Thank you. Thank you.
Thank you so much, Dr. Ankit, and all the panelists to join today's session. Please join us tomorrow session also. So good night, everyone. Thanks, Ashika. Thanks, Uday.
Yeah. Good night, everyone.